All right, as Dr. Pudavalli mentioned, I'll be focusing on perioperative neurocognitive functioning and its assessment um, in patients with low-grade glioma in particular, but also contrasting a bit with that of high-grade glioma populations. So before we get started into the data, I'd like to kind of cover what we mean when we talk about neuropsychological functions. And of neuropsychological functioning, one of the primary areas is neurocognitive functioning. And neurocognitive functioning can be split up into various domains, including attention and concentration. And we're talking about things like sustained attention, the ability to divide your attention, to switch back and forth. That can be both visual and verbal in nature. And there's also working memory, the ability to hold on to information within the mind. We also assess processing speed. That can be things like graphomotor speed, writing speed, reaction times, visual scanning speed. We also assess language functions, both expressive and receptive, so reading, writing, speech, comprehension, to get a broad picture of how language is functioning in the brain. We also function on or assess visual spatial functions. And by that, we're talking about things like constructional capacities, the ability to visualize and mentally rotate, the ability to perceive your environment accurately. We also focus on memory and assess memory, and we typically focus on three different aspects of memory: the encoding or the learning of information, the retrieval, the ability to get that information out of memory, as well as consolidation, the ability to hold on to that memory over time. Executive functioning is also assessed, and by that we're kind of talking about an overarching higher level cognitive abilities. So the kind of the conductor of the orchestra that is involved in the planning, the problem solving, flexibly solving, negotiating your environment, as well as organizing your environment. We also assess some motor functions, particularly upper extremity strength, manual dexterity, coordination, and gait. And we are also interested in affective factors. These can also impact cognition and cognitive abilities and performance on our tests, including things like depression, anxiety, neuropsychiatric symptoms such as psychotic symptoms, hallucinations, delusions, can also point to differences in etiologies of these different cognitive disorders. So how do we measure these different domains of functioning? And we use objective formal testing. And why do we do that? You know, there are numerous patient-reported outcomes available, such as the functional assessment of cancer therapy. And it's very good. These self-report questionnaires are very good at getting at cognitive complaints or the patient's own experience of their cognitive functioning. However, self-reported measures are influenced by other factors that don't necessarily represent true abilities or true brain functions. Patients may have anosognosia, lack of awareness of their deficits. They may be biased in their own reports. They may actually magnify or be hypervigilant to very mild deficits that might be blown up in the patient's mind. And we know that self-reports are also very vulnerable to the influence of mood. And in fact, we see that self-reported cognitive functioning is most highly associated with depression, whereas depression has a very little impact, if any, on objective cognitive performances. What about screening tests, such as the MoCA or the MMSC? Well, they're fine for broad-based global cognitive impairments, but cognitive impairment can also be subtle, especially in the cancer setting. These screeners also don't comprehensively sample all of the domains of interest. And we see here, the top line represents the MMSC, the bottom line, a neuropsychological measure devoted to memory in particular. And you can see that there is no fluctuation in the MMSC after each dose of this therapeutic agent, whereas there's a lot of fluctuation that would have been missed if not using the more dedicated measure itself. Neurologic exam similarly is very important, very useful, particularly for these gross deficits, but it's not quite as sensitive as neuropsychological testing. And this was a study done where we looked at patients preoperatively with brain tumors, and about 15% were picked up on as having a significant cognitive deficit, whereas on testing, we had about 3/4 of patients show up as having impairments. So how do we get at these deficits? How do we test them? Traditionally, we use paper and pencil testing, still by and large the way it's done. These were initially developed from lesion studies like stroke, traumatic brain injury. These tests have large normative, healthy controlled data sets, as well as known group data sets where we know how the measures function in things like the different diseases. So Alzheimer's disease, brain tumor patients, frontotemporal dementias, and so forth. They're typically reliable. So test, retest, they're stable across time. They tend to have alternate forms, which is important to minimize the effects of practice. Doesn't really matter who is using them, they're pretty stable. They have small error, and they've been validated across numerous criteria, including concurrent, meaning that it's assessing the same thing as other measures within the same domain. It's predictive, it can predict outcomes, it can discriminate between diseases, and it's also diagnostically useful. Digital formats are gaining steam. They're easy to administer. You get rich performance data from them, and they're often consistent with functional neuroimaging or cognitive science paradigms. And some of these platforms are indeed well validated, but a lot of them are often lacking in adequate norms. And there's a lot more validation needed specifically to see how these platforms or how these programs operate within specific disease populations. So with the test results, how do we interpret the results? Well, we compare the way individual patients perform to demographically adjusted normative data, so healthy controls. It's kind of similar to the use of historical controls in clinical trials. And for the individual patient, we will determine a standard score. We'll derive a standard score. I typically use Z-scores, which is a mean of 0 and a standard deviation of 1. It's easy to interpret, and we use a convention in which a performance on a test that falls below a negative 1.5 Z-score, so 1.5 standard deviations below a healthy group, will be considered an impairment. Now, what about detecting change? Oftentimes, we're interested in following patients longitudinally. In terms of research at the group level, we can use various statistical methods, but we're often interested in the individual. Has this individual changed from their baseline? And so we can do a simple test retest difference, subtracting their follow-up from their initial performance, and use some sort of guideline, whether a change in 1 standard deviation would be considered a small decline. However, some of the tests are susceptible to practice effects, which may obscure our ability to detect change. So we have statistical methods called reliable change indices, which affect or adjust for practice and error, and they can be derived from regression-based equations. And these are very useful to adjust for practice and really determine statistically significant change at the individual level. These are somewhat more difficult to interpret when you're thinking about magnitude of change, because you typically get a result saying, well, they were stable, they were declined, or they were improved, but not necessarily how much in any of those areas. At MD Anderson, we use a core battery for our brain tumor patients. It's alterable, it's flexible, depending on the referral question and the time point of assessment. We keep it relatively brief, within about an hour to an hour and a half. Patients tend to be fatigued. They have other appointments, and we have to operate around their schedules. But the core battery typically taps those functions that we have previously covered. And we also measure visual memory, and we update the battery as new forms come out. We additionally employ computerized measures to supplement, whether it be attention, executive functioning, and so forth. Like I mentioned, we want to focus also on affective symptoms or mood, depression, anxiety. We also want to understand how their cognitive functioning impacts their daily performance, their functional status, as well as their ability to perform activities of daily living. So we measure that as well through self-report questionnaires, informants. And we also want to know, how does their cognitive difficulties or cognitive functioning impact their quality of life? So we'll give several questionnaires about quality of life, daily functioning as well, trying to get at the patient holistically. So preoperatively, we'll evaluate the patient ideally. And why do we do this? Well, first and foremost, we want to establish a baseline, a point of comparison to monitor them longitudinally, to see where they're at postoperatively. Have they changed? Following radiation, following chemotherapy, have they changed as well? We also want to inform the surgical team of functions that might be potentially at risk. If a profile indicates a deficit in a certain area, that may indicate potential eloquence near that tumor for that function at risk. We also want to help determine the feasibility of preoperative and intraoperative mapping, such as fMRI, TMS, or direct cortical stimulation. Patients with deficits, you may need to modify the technique, modify the tasks used, They may have aphasia, altered mental status, other cognitive deficits that limit their ability to participate. We can also inform prognosis, both risk of cognitive decline, as well as survival based on their preoperative cognitive status. So what do we know about baseline cognitive functioning? So one of the first studies was done by Tuca over 20 years ago, and they looked at varying grades and histologies, predominantly with tumors located in the frontal and temporal lobes, consistent with what we know about glioma location. They did testing before any treatment, and they found about 90% of patients had performances below the 10th percentile compared to controls, most predominantly within the domains of executive functioning and memory. And they found patients with larger lesions and greater edema had worse cognitive functioning, unsurprisingly. And left hemisphere lesions were associated with worse verbal memory and language, and right and bilateral lesions with greater visual spatial deficits, consistent with the stroke literature and what we know about functional neuroanatomy. There was no association with antiepileptics, and these results have been generally replicated and confirmed, including by our group. Now, not all tumors and not all deficits are created equal. Tumor grade and genetic characteristics can play a role. We know that baseline cognitive impairment is less common and less severe, but still frequent in lower grade patients, though estimates vary wildly and more studies are needed. We know that the differences between high and low grade tumors are independent of seizure status, steroid use, age, and lesion volume and location. What we think is happening is the lower grade tumors have lower lesion momentum, less speed of growth, allowing for more preservation of neuronal and cognitive functioning. And although this has been done in higher grade tumors, we've also found that IDH mutant tumors exhibit less severe deficits than their wild type counterparts. They have more preserved structural core in the connectomic studies. DTI shows greater preservation of white matter microstructure. So as in low-grade glioma patients, those with IDH mutant tumors in high-grade tumors may allow for greater neuroplastic reorganization. There are other tumor and individual molecular markers that may also influence cognitive outcomes, such as P53, ApoE status, and GFAP. Now, what about prognosis? So the prognostic studies typically involve GBM or mixed glioma samples, but we do know that early indication of impairment is associated with reduced overall survival. And we found that that's independent of RPA class, extent of resection, and KPS. Executive functioning and memory appear to be the most sensitive domains associated with survival and also the most frequently impaired. That being said, depression is also significantly associated with reduced survival, and patients who have both depression and executive deficits seem to convey worse survival of all. We can also predict postoperative cognitive outcomes from their baseline status. And those appearing to be at most risk of cognitive decline, particularly in memory and language, have left hemisphere tumors, tumors located within the temporal lobe, and greater preoperative functioning. So those with higher baseline levels of functioning may be at the greatest risk of losing some of that functioning. So we follow up postoperatively as well. So we want to determine cognitive outcome following surgery. We want to identify potential safety needs, such as driving restriction, their decision-making capacity, their need for supervision in daily life. The cognitive deficits we identify would be good targets for rehabilitation, and we can also recommend some strategies to compensate for those deficits. We also want to understand how those deficits may contribute to their quality of life, such as disability status and disruption to important life functions. And we also want to monitor for neuroplastic reorganization. There may be increased safety for repeated resection if these cognitive domains seem to recover, as well as the functioning appears to migrate on fMRI studies. We also want to be able to monitor longitudinal changes after surgery. So any changes associated with radiation, chemotherapy, and potential early progression. So after surgery, what do we know? We know that postoperative decline is relatively common in mixed glioma. Patients with left temporal lobe lesions decline about 60%, about 40% decline in right temporal lobe, and that's on at least one measure. It's most common, again, in memory and executive functioning. This may be due to the fact that language is often preserved and protected by pre- and intraoperative mapping techniques. We know that extent of resection is associated with the extent of decline in verbal memory and contralateral upper extremity strength. Now, that being said, while that's common in temporal lobe tumors, the frontal lobe tumors may convey less risk of decline. What we've actually found is that performing a supratotal hemispheric frontal lobectomy is actually pretty feasible. Less than 30% of patients show significant decline on reliable change indices. Similarly, low-grade glioma patients tend to have less risk of surgically acquired impairment. About 25% of left hemisphere and slightly lower right hemisphere patients will decline. Again, verbal memory showing the greatest risk, regardless of hemisphere. Again, we think that there's possibly more baseline reorganization due to the slower growth. And we know that postoperative decline is associated with hyperactivity, postoperative pathological hyperactivity and functional connectivity, both near the tumor itself and distally. So this distal broad disruption across the brain may help explain why verbal memory deficits appear even in patients with isolated right hemisphere resections. So we want to continue monitoring the patients. We want to see which patients recover. And there's very little data on recovery of functioning within the first few months of surgery. But there is some data suggesting that patients with aphasia postoperatively will recover by and large within the first month postoperatively. And they'll typically evolve into a subtle anomia, difficulty naming objects that doesn't typically impact their daily functions. Neuroplasticity is important in low-grade glioma patients. It may allow for safer repeated resections or staged resections. And the safety may be greater when you see changes accompanied in fMRI, relocalization of functions accompanied by improvements on cognitive testing. So it's promising, but we need more work in this area. So what do we know about radiation? Radiation, we know, causes neuroinflammation, direct damage to oligodendrocytes, vascular damage. This can lead to acute, delayed, and progressive effects. In the later stages, even leukoencephalopathies, which are irreversible. We know the hippocampus is particularly vulnerable. And there's been limited research examining the cognitive effects specific to radiation in glioma, but some studies indicate that at 6 months, a sizable proportion will have mild cognitive impairment, 10% with almost dementia-like syndromes. And we know that white matter abnormalities in the cingulate are associated with executive deficits, white matter changes in the temporal lobe associated with memory problems. But promisingly, especially in low-grade populations, there's some evidence suggesting that protons are safer than photons. Chemotherapy also poses risk of decline. Most of the research in this area has been done in non-CNS cancer, especially breast cancer patients. But we know that chemotherapies can cause neuroinflammation, oxidative stress, DNA damage. And this tends to result in a subcortical, frontal subcortical profile on cognitive testing with particular deficits in attention, speed of thinking, and aspects of short-term memory. This has been difficult to study specifically in glioma due to the impact of other therapies. In GBM, not low-grade glioma, there has been some indication, some study indicating that about a third of patients will decline after chemotherapy with temozolomide, despite remaining radiographically and clinically stable. So there is some potential impact of even well-tolerated chemotherapies like temozolomide. Similarly, some long-term oligo survivors after PCV have showed deficits and decline. But there's some indication that chemoradiation may even be milder in low-grade glioma, again, possibly related to this neural reorganization, this neuroplasticity. But there is counter evidence that some of the declines may emerge later. So to summarize, traditional neuropsych methods can be utilized to capture important cognitive endpoints in patients with low-grade glioma. Cognition is associated with both structural and functional changes, but these vary by grade, genetic characteristics, location, and individual characteristics. We know that various treatments, including surgery, radiation, and chemo, can have significant impact. And importantly, cognitive functioning is prognostic and related to important patient outcomes like performance status, functional independence. And this really underscores the importance of measuring and monitoring these functions and trying to intervene when deficits are encountered in the clinic. And I want to thank my collaborators and can take any questions if there are any. Thank you.